All right, let's get started. I know that you guys wanted me to talk a lot about the surgeries involved with pelvic organ prolapse and urinary incontinence, but I think it's really, really important that you understand the basics, because you can't do the surgeries unless you understand why you're offering someone the surgeries and what surgery to pick based on their exam. So that's why we're going to go over some basic stuff before I hit the highlights on the different surgeries that are available for pelvic organ prolapse and incontinence. So let's just hit a little bit of anatomy. This is your pelvic anatomy, your pelvic bone. Important here are these ischial spines, which are right here. These are palpable through the vagina, and they're a landmark we use in a lot of our surgeries. This is another view of the pelvic bone. Here's the ischial spine we talked about before. Attached to the ischial spine is the sacrospinous ligament, which goes from the spine to the sacrum. Get it? Sacrospinous. That's why. This is the sciatic, greater sciatic foramen, lesser sciatic foramen. This is the obturator and canal and membrane, or this is the obturator canal. But this is the area where if you're going to put a transobturator sling, that's the area that goes through. The sacrospinous ligament is something that we will attach the vagina to in some of our prolapse. I think you had a question about that last week. What nerve can be injured? There are some nerves and blood vessels that are very deep to this, like the femoral, but most often when you put a needle through this, you'll get one of the gluteal nerves. And so the patient will complain about some pretty significant butt pain. I don't know why my computer's so slow. Okay, so this is again just looking down the pelvic anatomy. The levator ani complex is a very important muscle group in the pelvis. This is very testable information. Levator ani complex is made up of 3 muscles. The current names of these muscles are pubococcygeus, iliococcygeus, and puborectalis. They don't show the puborectalis here, but the puborectalis goes from the pubic bone all the way around the rectum and back to the pubic bone like that. And it's really important for maintaining the angle in your rectum. It has to relax in order for you to defecate, as I can't remember who brought up last week. It's why squatty potty is so important, is that when you have your feet up when you're trying to defecate like that, it can help to relax your puborectalis muscle and help you defecate. But these muscles are very important in the support and stabilization of the pelvis. This is just another view looking the vagina. The muscle here, the landmark here really you need to pay attention to is the pudendal body. So this is a collection of muscles right here. The bulbospongiosus muscle comes into this. The superficial transverse perineal and deep transverse perineal muscles come in right here. And then the external anal sphincter come in. And that muscle group together makes up the pudendal body. You can see that here's the levator ani complex again, but it is deeper to these more superficial muscles. More anatomy. This is your uterus, your vagina. Uterus sacral ligament is a ligament that attaches the apical portion of the vagina to the sacrum. So uterosacral, so let's name that. The lateral cardinal ligaments are not as important for support as the uterosacrals are. They are important. I don't want to make them sound like they don't do anything. But generally when we're doing hysterectomy, we come right through these, kind of hugging the uterus and the cervix. When we do vaginal hysterectomies, this is where the uterine artery comes in. As you can see, the uterus, or the uterine artery and the ureter are very, very close together, which is why they can be injured. Vaginal hysterectomy actually has the rate of injury of the ureter is the least. It's more common to get it with open hysterectomy than with laparoscopic and then with vaginal. But it is very difficult to do a vaginal hysterectomy unless you have fairly significant prolapse. I don't know why my computer is so slow changing slides. Okay. Little bit, and see when I press the button twice, it goes too far. So just looking some more at the anatomy, this were again some questions you had last week. This is the bladder. This is the vagina right here. So in between the bladder and the vagina, remember I said this has lots of names, but generally people call it the pubocervical fascia. Well, here they call it the endopelvic fascia. But there's a fascia layer, it's generally referred to as the pubocervical fascia, that is in between the vagina and the bladder. It's what gets torn when you have a cystocele. It can tear laterally off. That's right, the arcus tendineus fascia pelvis, or it can tear medially. And so how you fix an anterior repair depends on where it's torn and probably also how you've trained. So that's the two important landmarks for your anterior repair. Now, why do women have so much trouble and why do their pelvic organs tend to start descending? Babies. Babies are the main reason. Not the only reason. You'll certainly have ladies with prolapse who have chronic constipation or some sort of connective tissue disorders. You'll also see, but most often the damage is done by being pregnant and having a baby. Now, vaginal delivery does do more damage to the pelvic floor, and here's why. There's a lot of tearing, stretching, and as the baby comes through, but you do still get some damage done just having a baby sit on your pelvic floor, so C-section doesn't necessarily prevent all of this. Just a side note, why does obstructive labor cause fistulas? This is why, because your pubic bone is right here and your bladder is compressed, and there's two hard surfaces, the baby's head, well, fairly hard surfaces, and the pubic bone, and it's pressed against that. And if you have an obstructed labor and it's pressed against that for long periods of time, that's how you get a fistula. All right, so terminology, they like to change the terminology every few years, but these are the ones you'll see most commonly. Anterior wall defect or prolapse is a cystocele. Apical wall prolapse or defect is either uterovaginal prolapse or vaginal vault prolapse. If you have a patient who has stage 4 prolapse and they also have a uterus, that will be referred to sometimes as uterine prosidentia. Posterior wall defect prolapse is a rectocele. Intracele is sort of a hernia in somewhere in the vaginal vault where there's some small bowel coming through, or another abdominal contents, but most likely it's your small bowel. So what are your symptoms? Vaginal bulge and pressure. You can have lower urinary tract symptoms with these. You can have difficulty defecating, needing to put your fingers in your vagina and push down or push up to help you have a bowel movement, or to urinate. That's called splinting. You can have some pain with intercourse. Lower back pain, it's debatable. Depends on posture. So if you're standing or holding or walking yourself funny because you have significant prolapse and we fix it, maybe your lower back pain will get better, but generally they're not related. In fact, a lot of these may or may not get better if we fix your prolapse. The only thing I really can guarantee will get better when I fix prolapse is the actual vaginal bulge. Pressure, vaginal pressure, that can be from atrophy. Lower urinary tract symptoms, they may just have overactive bladder. Difficulty defecating, they may have constipation. Dyspareunia, they may have that because their levator ani complex is too tight. They may have atrophy, they may be too dry. Splinting, believe it or not, this usually goes away when you fix prolapse, but not always. Sometimes people still have to splint after they fix prolapse, and it has to do with needing increased pressure within the rectum or the bladder, and putting your fingers and pushing helps increase that pressure. So that's why when I talk to a patient and I counsel them, I'm very, very careful to explain this, because the worst thing you can do is do a surgery and you're like, I did such a great job, that prolapse is gone, that patient's gonna be so happy, and they're like, well, I still have overactive bladder, I still pee all the time, that's what I wanted you to fix. And I was like, oh, well, I went and fixed the bulge, because that's what prolapse does, and it's a miscommunication. I didn't explain to them that fixing a prolapse won't necessarily fix their overactive bladder symptoms, because those are two separate symptom complexes. It may help. Having prolapse can make your overactive bladder symptoms worse, but it's no guarantee. And the patient just assumes, I have bladder issues and there's something hanging out of my vagina. Obviously those two are connected. And the answer is yes, They can be, but not necessarily. So you really need to be very clear with your patients about what you are surgically going to fix. So these are just your tools for the vaginal exam. This is the PopQ stick. This is how we measure prolapse. Okay, let's go over the PopQ in detail. All right, so the PopQ is essentially 6 points measured at the vagina with respect to the hymen. The hymen is 0.0. Any point proximal or above the hymen are negative numbers. Any point distal to the hymen or below it are positive numbers. All measurements, all of them, except for total vaginal length, are measured at maximal valsalva. So that includes genital hiatus, that includes pudendal body. All of them are valsalva except for your total vaginal length. So what are all these? And by the way, guys, I carry a lot of cards with all the PopQ measurements and what they mean and how to do it on me. So please just come ask me for them and I will give you one. I'm collecting them for you. I try to give one to all my residents who are on my rotation, but I'm more than happy to give them to you early so that you can use them, study them, especially for your exams. All right, point AA. The small a is for anterior vaginal wall. It is a fixed point, 3 centimeters, proximal to the hymen. The range of values that AA can be is -3 to +3. BA, small a, anterior vaginal wall. Most distal portion of the remaining upper anterior vaginal wall. So it's sort of your distal most point of prolapse. How much does the rest of the anterior wall come out? It can be -3 centimeters to positive total vaginal length. C, if you have a uterus, C is cervix. If you do not have a uterus, C is cuff. So most distal edge of the cervix or the vaginal cuff scar. D, that's your posterior fornix. That is underneath that cervix. Doesn't apply if you don't have a hysterectomy. If you've had a hysterectomy, it'll either be marked with an X or it'll just be blank. AP, P, small p, or posterior. Again, it's a fixed point, 3 centimeters proximal to the hymen. Same thing for the BP, which is the posterior vaginal wall. Genital hiatus, that is measured from the middle of the external urethral meatus to the posterior midline hymen. The pudendal body is measured from where you stopped your genital hiatus to the middle of the anal opening. And then total vaginal length, that's the only measurement you take without valsalva. That is the depth of vagina from point D, so posterior fornix, unless they don't have a uterus, and then it's point C, when reduced to a normal position. So if they have a lot of prolapse, I will push the prolapse back in and try to get a measurement of what their total vaginal length is. Okay, so AUGS, American Urogynecologic Society, has a great website. This is free. Really encourage you guys to go and look at this website, and especially before your exam, practice with these numbers. You can put these in, okay, and practice, and this will show you what that looks like so that you can get a better idea. So this is just standard, and this is just how, this is genital hiatus, this is pudendal body, these are about 3 centimeters from the hymen, this is where your C is, here's your D point, this is posterior fornix, that's your total vaginal length. So how do you stage this? Stage 0, you are not going to see this very often unless you have a woman who has never had a baby or has had radiation and her vagina does not move. So basically all these numbers are -3, and either C point or D point don't move more than about 2 centimeters. That'll be stage 0. Stage 1 is basically if it's not stage 0, but it hasn't come out to 1 centimeter to the hymen yet. Stage 2, the leading edge is somewhere between -1 centimeter behind the hymen to 1 centimeter in front of the hymen. Stage 3 is greater than 1 centimeter ahead of the hymen to 2 minus vaginal length. And then if you're at stage 4, you are somewhere 2 minus vaginal length. So just for example, your total vaginal length is 8 centimeters. If you have an 8 centimeter long vagina, if your D point is -6, -7, or -8, or your C point if you've had a hysterectomy, and the rest of these numbers are -3, then you are at a stage 0. If your leading edge of prolapse is between +2 and +5, then you're at a stage 3. Why? Because 8 -2 is 6. So that means that the leading edge is less than 6. It's between +1, like +1.5 to 6, but not equal to 6, because if you are at 6, 7, or 8, you are at stage 4. Okay. Does anyone have any questions about that? Because we're gonna practice, so ask now. I can't, because I'm doing this, I can't actually see Zoom, so nobody has questions. Okay. All right, let's practice. Who wants to go first? In honor of it being the Chiefs last week, I'm going to leave them alone and pick on the new Chiefs. Evan, are you still on? Is anybody on?
I'm here.
Okay. All right, let's do this first one. So let's just walk through it. This is AA. This is your anterior vaginal wall right here.
Yeah.
What do these numbers mean to you?
I mean, we said, oh.
I have no idea why that happened. I did not do that.
That's not what that is, Andrew. That's a female part. No. So the 2 zeros. So we said that AA and BA are fixed points 3 centimeters proximal to hymen. So that means that that the anterior vaginal wall is at least at the hymen. So.
Yes, you are correct. The anterior wall is at the hymen. Now, C point. What does this mean? Where is C relative to hymen?
It's like 6 or 7 back, right? 4 centimeters back.
Yeah, it is 4 centimeters back from the hymen.
Back to the hymen. I thought you meant normally. I'm sorry.
Yeah. No. So C point is taken at Valsalva.
Okay.
So C is 4 centimeters back from the hymen.
Yeah.
All right. So D is X. What does that mean?
They had a hysterectomy.
You are correct. This is your posterior wall. What does this mean?
It means they're 1 centimeter distal to the hymen with the posterior wall.
Well, proximal, technically, it's behind the hymen.
Oh, it's negative. Sorry. Might be. Yep, I'm stupid.
And what does this mean?
Total vaginal length is 9.
Yes. Okay. So, and this is?
Genital hiatus.
Good. Is 6 centimeters, and pudendal body is 4. Now, these numbers right here are never going to be negative. It's not like you can have a negative genital hiatus, pudendal body, or total vaginal length, okay? So, just the overall picture of this one. This patient has a stage what anterior prolapse?
Stage 1.
No.
Oh, it's 2?
Yes. So, stage 2.
Okay.
All right. The other thing that is of note is that the apex comes down more than halfway from the total vaginal length. Okay, so that's important surgically. If their apex comes down that much, and all you do is fix this anterior wall, I can guarantee you it's going to fail because you've done nothing to resupport the apex that has come down 5 centimeters. All right, Liz, are you back from the restroom?
Yes.
Okay, here's yours. Go ahead and just interpret what this PopQ means.
Do I have to touch this? No. Okay. So AA and BA being +2 mean that the anterior vaginal wall comes 2 centimeters beyond the hymen. And C +1, same thing, that the cervix comes down 1 centimeter beyond the hymen. On the posterior wall, the posterior wall comes not that far down, so 1 centimeter above, like proximal to the hymen. Genital hiatus is 5, pudendal body is 3.5, total vaginal length is 9, and D point is 3 centimeters above the hymen.
Yep. Okay, so what stage is this?
So because the anterior vaginal wall is prolapsing more than 1 centimeter beyond the hymen, that would be stage 3.
You are correct. So you would take the stage of the greatest prolapse. So this is at stage 3, anterior wall. Cervix is at stage 2. That's notable. You should know that. But you would call this a stage 3 prolapse. Now, you would obviously need to do something about this. And of course, they have a D point, they have a C point, they have a uterus.
Yeah.
Or I guess I should say they have a cervix. If they've had a hysterectomy, but it was a supracervical, they could still have a D point. All right, Casey.
Yes. So first, is that top dark blue middle box supposed to be BA? Or, yeah, BA, not BP?
Sure is. Good catch.
Yeah, just making sure.
Yeah.
Okay, so this person, first of all, has a hysterectomy. And then total vaginal length is 8. The cervix, or vaginal cuff, sorry, comes to -6, so a little bit of a drop down, but not very much. The anterior wall, both AA and BA are -3, so the anterior wall is intact. The posterior wall goes to +1, so that's 1 centimeter distal to the hymen. So there is a rectocele, and I would say that is a stage 2 prolapse.
You are correct. Good. Nora, are you on?
Yes, I'm here.
All right. Take a look at this one right here.
All right, so she's had a hysterectomy. AA is +3, so it's 3 centimeters beyond the hymen. BA is +7, so 7 centimeters beyond, and then +7 for the cervix as well. Genital hiatus is 5, and then total vaginal length is 8. AP is +3, so you're 3 centimeters beyond the hymen as well, and EP is +7, so you're 7 centimeters beyond as well. So this is significant prolapse. It's stage 4.
You're right. It is stage 4. Good. All right. I did this one based on the discussion last week because I thought it was so weird. So I'm just going to walk you guys through this because we need to move on. Anterior wall and posterior wall are both fine at -2. And posterior wall is also fine, -1.5. You got a total vaginal length of 8, but your cervix is hanging out. It's 1 centimeter past, but your D point is still really far back. You'll notice that from total vaginal length, D point doesn't actually move very much. This is cervical elongation. So really the only thing that's moving is cervix. This is someone you would just do a tracheolectomy on and remove their cervix. Does that make sense?
Yeah.
I wouldn't be worried about resuspending their apex. Their D point is fine. But if their D point, let's say their D point was, I don't know, 4, -4. And that means it's coming down halfway, and their C point was +3. Yes, they have cervical elongation, but they also have an apex that's too mobile. So yeah, you're probably just going to need to take the cervix, and you're going to need to do an apical suspension. All right, so like I said, this is a really great interactive guide. You can change these numbers, and it will show you what the prolapse looks like. So please, please, please play with this. All right. Here's your stage 4 prolapse. That's what that looks like. All right. So interocele versus rectocele, this can be kind of difficult to differentiate. In fact, I've certainly made mistakes on exam and haven't discovered it until I was in the OR doing the case that, oh, this actually is an rectocele. This is this interocele. But basically what you want to do is put one finger in the vagina, one finger in the rectum, and have the patient bear down. If you feel some bowel coming in between your fingers, that's probably an interocele. All right, so the goals of treatment are to alleviate your symptoms, maximize your bladder, bowel, and sexual function, restore your pelvic support, and try to prevent any new defects.
I have a quick question, Dr.
yeah.
Hammett, about the interoceles. How often do you see that, and does it happen like usually after they've had a hysterectomy and they just have a vaginal cuff? Because I feel like that plane between the rectum and vagina should be intact and not have an interocele unless there was like prior surgery there or something. Is that right?
Yes, that's a very good point. Most of the time when you get an interocele, you've had a hysterectomy.
Okay.
Not all, I have seen it where you'll have one. The most common interoceles you'll see and I see are status post radical cystectomy. Those patients, after you've taken everything out, don't have very good anterior support, or and so you'll get an interocele anteriorly or through the cuff. But yeah, you're right.
Okay.
Thanks. Sure. So treatment options for prolapse, you can do observation, you can do physical therapy. Now, when you do physical therapy, you should tell the patient this is not going to make your bulge go away, but it can decrease your symptoms of the bulge. So you may not know that you have a bulge, but it won't, or you may not be as bothered by it, but it's not going to like help resuspend your vagina. Pessaries are great non-surgical options. They do have to be fit. If they're fit correctly, they should fit very comfortably, and they should stay in place. If they cause any bleeding, irritation, uncomfortable, they need to come out. So now let's move on to surgical considerations. So this is why the PopQ is important. You really need to know the stage and location of the prolapse. You need to understand what your patient prefers and what their goals of surgery are, and then you need to do what you are comfortable with. If you've not been trained to do a certain surgery, don't do a certain surgery. I will tell you, when you offer patients surgeries, you should always offer them all the surgeries. If they pick a surgery you don't do, send them to someone that does it. However, most patients appreciate to know the knowledge, but will want you to do it. So they'll pick one that you do. So it's not like you're just going to give away all your patients. You may pick somebody else, but you should appropriately counsel them. Just because you don't do a certain surgery doesn't mean that's not an option for the patient. So what are your big surgical decision makings for prolapse based on? Well, there's 3 compartments and the genital hiatus needs to be addressed. So anterior, apical, posterior. Your hysterectomy is traditionally done if they have apical prolapse, but we actually have some really nice new studies that show it may not be necessary. So you can do a uterus sacral vault suspension and just leave the uterus in place. You can put mesh on the uterus. I've not done that. I'm not comfortable with it. I don't know. So I probably won't, but doesn't mean I can't offer it and tell them where to go if that's what they choose. This is really important to realize, that because there are some women in some cultures that do not want to lose their uterus. In the South, it's pretty common. Women are like, oh yeah, everyone has a hysterectomy down here. But in other places, it's not. So if a woman is attached to the uterus, that is perfectly fine. You do want to counsel them that it doesn't do anything for them after a certain age. It won't really affect their hormones if you leave it in their ovaries, that sort of thing. But if they're attached to the uterus, that is okay. If the apex of the vagina descends more than halfway down the total vaginal length, you really need to support the apex, or your prolapse is going to come back. If the patient has a widened genital hiatus, so genital hiatus should be about 3 to 4 centimeters. If it is bigger than that, you really need to think about decreasing its size because it'll decrease your risk of recurrence. I usually have 2 fingers. They should easily go into the vagina, slightly separated, and that tells me that they're probably going to have good room for penetration.
Dr.
All
Hammett,
right, so,
on that last slide,
Yeah.
one quick question. The apex of the vagina descending more than halfway the total vaginal length, that's measured, is that D, the posterior fornix, or how do you measure that?
Yeah, so that's a good question. It depends. So with prolapse, you usually get some cervical elongation. So if the point doesn't move at all, like let's say you have a total vaginal length, if you've not had a hysterectomy, your total vaginal length is usually about 9 or 10. to 11. Let's say that you have a total vaginal length of 10 and your D point only comes to 8, then it would be exceptionally difficult for me to do anything vaginally. But if your D point comes all the way down to, let's say, 6, which is not half the length, but you've got a cervix that started to elongate to 3 or -3, then I am probably going to consider doing an apical suspension. So it's a little bit knowing what you can take out vaginally, and a little bit being like, if I'm going to fix this, yeah, the cervix is a little long, but just cutting off half the cervix and then, resuspending it doesn't really make sense. And they're already starting to have some descent. So there's not a hard, fast rule. It is easier if they, if everything's coming down, you're like, oh, well, this is a lot. But there are some times that I look and say, how easy would this be for me to get out vaginally? Because the higher the D point, the harder it is for me to get into the peritoneum posteriorly. And so that's kind of how I judge. Now, if for whatever reason they really want, I've had a lady come in who didn't have very significant prolapse, but she was really into CrossFit. She was really into heavy lifting. She had a little bit of prolapse, but what she really had was some cervical dysplasia. So I went with gynecology to do the hysterectomy, and the reason being I am only privileged to do hysterectomies for prolapse, and she did have a little bit of prolapse, but not significant. It was still in the stage 1 zone. So they took out the uterus and cervix for the cervical dysplasia because that's what she wanted, and then I resuspended her vagina back up. So there are situations where you do kind of have to use a little bit of just experience to what you want to do. But typically on your exam, at least, they're going to give you something that's fairly obvious. SASP questions notwithstanding, because they're terrible.
Okay, thank you.
So what are your prolapse surgeries? So if you're going to fix your anterior wall, you can do a midline plication. That's your just standard cystocele repair. You can do a paravaginal repair. You can do that vaginally or you can do that abdominally. A paravaginal repair is the lateral repair that uses the arcus tendineus fascia pelvis. Then you've got your apical repairs. So you can do a sacral cotopaxi. That is done intraperitoneal, and that does use mesh. I should mention that a paravaginal repair generally uses a graft, but I don't use mesh in that area. Some people will. Another apical repair is a uterosacral vault suspension and a sacrospinous ligament fixation. And we'll go over all these and how they're different and why they're picked. But those are your main 3. You will occasionally on your exam see a really old one with a different name and you're like, I've never even heard of that. I may have heard of it, but I've never done one. It's not the answer to the question. They've thrown that in there because they need another answer. It's generally going to be one of those 3 if you're doing an apical repair. Posterior repair, you can do a midline plication. It's the same pretty much as an anterior repair, just done on the posterior wall. If the hiatus is too large, you need to do a perineorrhaphy at the same time. Interocele repairs, there's a whole bunch of these. They have a lot of names. Site-specific ones are done very similar to hernia repairs. You just take off the vaginal epithelium, you do a purse string suture several times, and you fix your hernia. You can do a midline plication. You can do something called the McCall's, which I'll talk a little bit more about in a bit. It's an abdominal one. It basically just obliterates the cul-de-sac. And then you do have obliterative procedures. Colpocliesis and colpectomy are essentially the same procedure. The difference is if you have a uterus and a cervix, you have to leave channels for the uterus to drain. The reason being, even if they're postmenopausal, they can still have some blood, some bleeding, and you'd want to know about it if your 70-year-old starts having vaginal bleeding. Or they can have some secretion, some discharge, that sort of thing. The uterus has to have some way of drain. So when you close the vagina, you have to leave tunnels so that the cervix can drain. A colpectomy, basically that just means remove vagina. So that means they have got no uterus and cervix. You don't have to leave any channels. You take off all the vaginal epithelium, every single bit, and you just close that sucker right up. So let's start with your traditional anterior wall. So this is the cystocele. you would make a midline vaginal incision into the epithelium. Those of you who've worked with me know, but just so everybody else knows, it drives me insane when people call it a vaginal mucosa. It is not a mucosa. Your vagina does not make mucus. That is your bowel. The vagina is an epithelium. The discharge is an exudate or transudate. It is not mucus, okay? So in your op notes, for the love of God, please do not put vaginal mucosa, because I will be annoyed as I correct them. So you're going to make a midline vaginal incision through the epithelium. You're going to dissect the epithelium away from what? The pubocervical fascia. Then you are going to plicate this pubocervical fascia. You will trim the epithelium and you will close the epithelium. This is not a difficult surgery. This does not take very long. But if you do all this and they have significant apical prolapse, I can guarantee you it's going to come right back. All right, lateral defects. So this is the pubocervical fascia right here. This is your arcus tendineus. This looks a little funny because it looks like it just holds up the urethra, but it really is holding up the bladder, which you see a little bit better here. So this is what you're doing. If you're doing this abdominally, you are reattaching the fascia, the pubocervical fascia, to the arcus tendineus fascia pelvis, okay? This I generally do robotically. You can certainly do it open. I have. When we do it open, we generally do it over somebody's finger. I always feel bad for that person because this is the vagina, because you're pushing this tissue up and you're trying to push the bladder away so that you don't stitch the bladder to the arcus tendineus fascia pelvis, because then you have to take your stitches out. So this is a lateral repair. This is done abdominally, but you can do it vaginally. So here's how you do it vaginally. So here we've opened the vaginal epithelium right there. This is the pubocervical fascia. It is really difficult to see over here in order to put some stitches. So after you dissect, you'll kind of push your finger until you get to the pubic bone and you can feel the pubic bone. This device right here is called a capio. What it does is when you deploy it, it releases a suture that goes in and then right back into the device. So that, and then when you pull it out, your suture is nice and stuck in the arcus. We use this a lot when we're trying to put sutures in ligaments that we can't see. As you can imagine, it's super fun when it starts bleeding and you can't see in there. But generally, this is not a highly vascular area. So we put usually about 2 to 3 sutures through this on this side and through it on the other side. Then, so this is just, they put 4, which is impressive. There's usually not room to put 4. And you're trying to go back to the ischial spine if you can. Like I said, that is a landmark that you can palpate. Am I hitting the wrong buttons? Why won't this move? Okay. Okay. So, like I said, usually we put a graft when we do it vaginally. So what we're doing is we're attaching the graft to the arcus tendineus. So a lot of times you'll have already done a midline plication. So you'll do a midline plication of the pubocervical fascia, and then you will put a graft and you will cut it to fit on both sides. And then this is what it looks like. So this is your vagina, this is your bladder, you've plicated the pubocervical fascia, and then you've put a graft in between. Posterior wall prolapse, this is your rectocele repairs, are actually much more successful than your cystocele repairs, about 76 to 96% success in reducing the bulge. Minimal success when it comes to anorectal dysfunction. Why? Because that is a very complex disease process, lots of constipation, lots of bowel issues. I can fix the bulge. I cannot promise that you'll poop better. Levator ani plication is something they used to do. They used to try and go get the levator ani muscles and bring them midline to help support. That caused a whole lot of pain issues. It also created this weird shelf that gave within the vagina that kind of gives you a lot of pain with intercourse. It can also cause constipation and incomplete rectal lengthening. So if you ever see this on a test, the answer is don't do it. The other thing I don't recommend is putting mesh anywhere in this area for multiple reasons. Just don't put mesh here. Sorry, I don't know why there's such a delay. Okay, so here's the posterior repair. Generally, we inject like a solution of marcaine and epinephrine into this area. This is a highly vascular area, even in older women. We inject this anteriorly too anytime we're doing this, but what that does is it not only helps with hemostasis, but it also gives some hydrodissection. So then you're going to make an incision. Here, they like to do a triangle incision. I actually usually do a diamond. So I'll come up here and here and here, and then you'll go back the rest of the way posteriorly. So you remove all this epithelium on the diamond, and then you separate the vaginal epithelium from the rectovaginal fascia, and you'll make a little incision, and then you'll separate all that out. Apparently that's all the pictures I have. After that, it is the same as an anterior prolapse repair. You're going to plicate that tissue, and then you're going to trim the epithelium, and then you're going to close it. And this diamond that you've created, that is actually when you do the perineorrhaphy. You try to create, instead of it being like a horizontal plane, you want to create like a vertical and horizontal plane where they come and meet. It's sort of hard to explain unless you see it, but you're reapproximating the hymen. You don't want to make it too tight. You want the patient to be able to be sexually active if she so desires. But you need to help bring back in that pudendal body, so those stitchers are put pretty wide because you are trying to get that transverse superficial perineal muscle back into place. You do have other options for posterior wall prolapse repair, site-specific repair. I will do this occasionally. So with this, the tear has occurred longitudinally. So the rectovaginal fascia has split down the midline. But let's say that it didn't tear down the midline. Instead, what it did was it tore horizontally here and separated from the pudendal body. Well, then all you really need to do is bring back that rectovaginal fascia back to the pudendal body. And so that would be like a site-specific repair. Graft augmentation, if you're going to do this, please use some sort of biologic. Do not put mesh in this area. And again, perineorrhaphy to help support if they have a widened genital hiatus. So apical prolapse. Here's your stage 4 prolapse. Sacrospinous vault suspension. So why do I pick what I pick and when I pick it? So sacrospinous vault suspension, I do not do a lot of these. I didn't, and part of it is, remember how I said that how you train is sometimes what you're going to pick? Well, I did not do very many of these in fellowship, only a few. So I'm not as comfortable with it. So when I do one of these, I ask one of the urogyns, Dr. Northington, who does a lot more of these than I do, to be available to help me because I'm just not as comfortable doing them. Uterosacral vault suspensions, I do them all the time. So they're my go-to one. And then abdominal sacral cotopaxis uses mesh. And while it does not have anywhere near the complication rate of, say, a PopQ mesh kit, it still has complications. You can still definitely get mesh erosions. You can have pain. In general, I only offer someone a mesh surgery if they have already failed a native tissue repair. So these are considered native tissue repairs. Why? Because they only use the tissues you have. So sacrospinous vault suspension, why would you pick a sacrospinous vault suspension? Well, first of all, it's extraperitoneal. You don't have to go into the peritoneum. That can be really important for some patients that you do not want to go into the peritoneum for. It's also done vaginally. So there's some benefits to that. Uterosacral ligament fixation. It is intraperitoneal. You've got to go into the abdomen. You can do it vaginally. It is very difficult to do these vaginally if they've had a hysterectomy. Getting into the peritoneum vaginally, if you don't have a uterus, is fairly difficult to do. So I will generally, if they've already had a hysterectomy, I will do these abdominally, usually robotically. Abdominal sacral cotopaxi, also intraperitoneal, also uses mesh. Colpocliesis. So this is your obliterative procedure. It is also extraperitoneal. It is vaginal, but you do have to have significant prolapse in order to do this, or it can be just exceptionally difficult. It may not be possible. So you really need some significant stage 3 or stage 4 prolapse if you want to do any sort of obliterative procedure. You also have to not want to have penetrative intercourse again. This is exceptionally difficult to reverse, so we just tell people we cannot reverse it. So if you want to have penetrative intercourse again, do not have a colpoplasis. On the other hand, for your older women who are no longer sexually active, who are not in good health, these are excellent procedures. They are low risk. They have very little to no pain. They recover very quickly, and they are some of the happiest patients because they've gone from having, 8 centimeters of vagina hanging out to nothing. And it's, it can be done as an outpatient. It can be done with epidural. However, I usually don't recommend an epidural because it can take several hours to do, and that's just a long time to lay on the table and be awake. All right, sacrospinous vault suspension. This is when you're going to bluntly feel through, after you've dissected and can get your finger back here, bluntly, you're going to feel the sacrospinous, the spine, you're going to feel the ligament. This is where the sutures are going to go. So if this patient also has anterior prolapse, you're going to make your incision anteriorly, take the vaginal epithelium down, placate the pubocervical fascia, and then you're going to kind of bluntly dissect until your finger reaches this point. If you have posterior wall prolapse but no anterior, then you're going to do the same. You'll make your incision posteriorly, get the rectovaginal fascia, plicate it, and then bluntly go back with your finger. So you can enter this either way. Then you're going to pass 2 non-absorbable sutures through this ligament, approximately 2 centimeters medial and 1 centimeter cephalad to the spine. So most people do not have enough vaginal length to do this bilaterally. If you were able to do it bilaterally, you would not cone the vagina to one side, but as you can imagine, you'd have to have a pretty stretchy, long vagina in order to do this. So most of the time, this does cone your vagina to one side, which predisposes you to anterior vaginal wall defects. Complication, hemorrhage. This is not an area you can see very well, and it is super vascular, so it bleeds a lot. Buttock pain. This is probably one of the main reasons that it's not my favorite. These women have a ton of buttock pain. A lot of times it goes away with time. Sometimes it doesn't. Nerve injury. Rectal injury is not as common, but can happen. So here's your uterosacral ligament suspension. So what we're looking through here is the vaginal cuff. So you've already taken the uterus out. This is down here is your rectum sigmoid. Here are your uterosacral ligaments. Everyone does these a little bit differently. I usually only use 2 sutures, but you can use up to 3. You can use permanent, you can use absorbable suture. I use a combination of both. But you pass them through the uterosacral ligament. You then pass them back through the vagina, and how you do that depends on if they're absorbable or if they're not absorbable. If they are absorbable, then you can come all the way through the vaginal epithelium. If they are not absorbable, then you cannot come through the vaginal epithelium. They need to stay on the inside of the vaginal cuff. This is just another way of looking at it. If this is your uterosacral vault or your uterosacral ligaments, reattach it to the vault. So what's the big risk with this? Well, uteral injury, ureteral injury. However, when I say injury, I really mean kinking. I don't mean that you've cut the ureter in half. So Matthew Barber did a really nice study that showed that 11% of the time when you attach the vaginal cuff to the uterosacral ligament, you will kink the ureter. And it's real important that you know that before you resuspend. So once we put these sutures in, we'll do a cystoscopy. We'll give the patient some indigo Carmen, and we will put those sutures on tension. If the ureter stops going, then we'll replace those sutures in a different place. And the reason is the uterosacral ligament is very close to the ureter. All right, moving on to abdominal sacrocolpopexy. These are done abdominally, or they can be done robotically or open. We usually do them robotically. It's a lot easier to do them robotically, actually, because suturing on the posterior wall of the vagina is very hard to do open. So you incise the peritoneum right here over the anterior longitudinal ligament. That's a test question. Anterior longitudinal ligament. That's what you're attaching it to at S2 or S3. You're going to put 2 to 3 permanent sutures. I usually use Ethibond in, and that's where one piece of the mesh is. Now this is a Y mesh, so the part of the Y that normally the Y stands on goes to the sacrum, and then the 2 leaves of the Y go to the anterior vagina and the posterior vagina. So what you'll do is you'll make an incision in the peritoneum, and then you'll essentially create a bladder flap. You are going to dissect down and push the bladder up, and just be able to see the anterior vaginal wall. And then you're going to do the same. You're going to dissect the peritoneum off the posterior vaginal wall, and then you're going to attach the mesh. I usually use permanent. I am pretty serious suture. I'm pretty seriously considering switching to a non-permanent and see how that goes. Generally, if you have failure after you have do a sacral cotopaxi, which isn't all that common, it's because the mesh is avulsed away from the vagina. And complications include mesh erosion and small bowel obstruction, which is why you close the peritoneum over the mesh so there's no mesh visible within the abdomen, because you don't want mesh to get stuck down. It's fairly successful at 60%. I just realized I'm out of time, so I'm going to go fast. Colpochleasis, this is a good one to do. What you do is you take off the vaginal epithelium. So this is taking off the vaginal epithelium. You do it anteriorly and you do it posteriorly. Come on. And then you suture the anterior wall to the posterior wall. By doing it this way, you create this tunnel, because here's your cervix, and you're going to create this tunnel laterally too. And then you will suture this part to this part, this part to this part, this part to this part, until this epithelial line meets the epithelial line on the other side, and then you just close it like that. It's one of those surgeries that's boring to do, but super satisfying. These are different types of interosseal repairs. I wouldn't worry too much about these. Usually these involve obliterating the cul-de-sac. And you do that by taking the uterosacrals and attaching the posterior peritoneum and suturing them together. Anyway, generally you improve the bulge. I've talked about this. We're not going to talk about incontinence because prolapse took all our times. Okay, sorry I ran late.